starts. So now that it's 6 after, let's just go ahead and introduce the session. My name is Ria Dange. I am a medical student at the University of Pittsburgh, and I'm also one of the G4 Alliance SOTA Fellows for this year, specifically working with the Africa Working Group. I've been working quite a bit with the Africa Working Group Chair, Irene Daraza, and Mohammed, and I'm excited to start working with Dr. Phillips, our new co-chair, who's fortunately joined us today. One of the things that we do in the Africa Working Group is the monthly speaker series. And this month, we have a very special presentation from Dr. Alexandra Golby, a professor of neurosurgery and radiology at Harvard Medical School, as well as the principal investigator of NousNav, a low-cost neurosurgical navigation technology that she's been working on researching and implementing through various partner sites in Africa. Dr. Golby recently presented her innovation at the Congress of Neurological Surgeons meeting in October in Houston, Texas, and won the Innovator of the Year award for it. So we're very excited to have her. And please take it away, Dr. Golby.
Great. Thank you very much for the invitation. And I'm so pleased to get to know you all because I think our goals align a lot. And becoming part of a network of similarly like-minded people, I think, is one of the key steps for our efforts, but also to help bolster other efforts. So I am a neurosurgeon, and so I'm going to speak largely, almost exclusively about neurosurgical applications, which within the G4 scope is obviously a small piece of what you all are working on. But I think it's also an interesting topic when we talk about technology, because neurosurgery has been technologically driven since day one. And our ability to take good care of our patients really has evolved as technology has evolved from imaging to the operating microscope, et cetera. So in a specialty that is so technology dependent, how do we think about scaling that and democratizing that to places that have less access to technology? And that's what I'm going to talk about a little bit today. Oops, sorry. So I am at the Brigham, and that is the home of Harvey Cushing, who became the surgeon-in-chief in 1913. And that is where he developed a lot of the techniques which took neurosurgery from intracranial neurosurgery from about 50% mortality to about 10% mortality. And some of those things that were developed included techniques which he documented meticulously. We actually have his books, his log books of all of his cases, but also technology. And one of the key challenges in intracranial surgery was hemostasis, which was really limited to placing clamps on blood vessels, which for anyone who's worked in the brain really does not work. The brain is so soft and fragile, the blood vessels are so tiny. And he teamed up with an engineer, William Bovey, to develop the first electrocautery unit. And this is still used everywhere around the world, including at the Brigham in a slightly modified, updated form, but was really a key to that great improvement in mortality from 50% to 10%. And so that kind of idea of surgeons teaming with technology experts, engineers, and more recently, experts in computer science, electrical engineering, and image processing and AI is really the space that my group works in. And since the development of the electrocautery, there's been a large number of advances, as I alluded to, that have really made brain surgery much better. So frame-based stereotaxy was developed in the 40s, and is still in use, although it's less used now that we have other techniques such as frameless navigation. Cross-sectional imaging with CT and then MR was critical. And then the adoption of some of these imaging methods into the OR in the form of intraoperative imaging. So here actually you see the double donut, which was the world's first intraoperative MRI, developed at the Brigham in the 90s. And since then, intraoperative MRI has earned a place in tertiary centers doing high-level neurosurgery. But it is extremely expensive, extremely resource-intensive technology. And one of our goals in our center, which is actually the National Center for Image-Guided Therapy, has been actually to use these very high resource platforms that we have, and currently we have a suite called Amigo, to use them to develop and then validate lower cost, less disruptive technologies that try to provide the same level of guidance or nearly the same level of guidance as these very expensive technologies. And that's not just for the developing world, it's for everyone. So, for example, even at the Brigham, the birthplace of intraoperative MRI, we only have one intraoperative MRI. It's shared by many services, and therefore it can only be used in a tiny fraction of our cases. So we need, even at the Brigham and other sites in developed countries, we need tools that are less resource intensive and require less time and are less workflow disruptive. In that vein, we have had a long history of working with open source software. And so we have developed a 3D Slicer, which some of you may be familiar with. It's an open source platform which allows image analysis. It's been in development for close to 30 years now. And it is open source, so it allows users to contribute to it. It's very well curated by a group of very dedicated people, so that it has a lot of robust and always growing capabilities, but is pretty stable. Nevertheless, it is still a research platform. And we've had a great interest in specifically using this for various applications in the developing world. So one application has been in teaching anatomy. And so in a number of countries, particularly those that don't have cadaveric dissection, there's a drive to using electronic media for the purposes of teaching anatomy. And there are companies developing proprietary anatomy teaching devices, but those are extremely expensive and require ongoing subscriptions. There's also been a lot of interest in using this for various types of applications. And so, for example, Slicer Baby Steps is an application that was developed by some colleagues of us at National Children's Hospital to develop customizable 3D printed molds to help babies who are born with clubfoot. So the casting method of clubfoot correction requires a certain amount of expertise, but is fundamentally fairly low cost. But their thoughts were that this was not available to many, many children in developing countries, particularly those at some distance from healthcare centers, because it requires, I think, weekly or biweekly application of these casts. And the travel necessary to do that really precludes a lot of kids from getting this therapy. And so the idea was, if you could harness technology to make the therapy more available by reducing the need to travel to a certain center of expertise. I encourage anyone with an interest in this area to look up Slicer. It has a lot of capabilities, and increasingly we are specifically interested in developing applications for limited resource settings. Actually, you can see here in the corner, the bottom corner here, this is phantom work to use Slicer and ultrasound for percutaneous nephrostomy. And this is work that has been led by some of my colleagues at Queen's University in Canada, my colleagues at the Brigham, and then a group in Dakar, Senegal, for percutaneous nephrostomy. Another area in which we are active is how to help democratize access to even open source software. So the other thing about Slicer is that it's a little bit daunting sometimes to start working with it. And especially depending on your experience with computer science. But we developed actually a Slicer chat. So this is a large language model that was built out of the very extensive forum. So there's an ongoing discourse forum where you can ask questions, and there's extensive documentation, as you might imagine, for something that's been open source for almost 3 decades. And so one of my graduate students, Colton Barr, built this large language model. We're still working on it, but the idea is, can you have basically a kind of tutor to help you when you have questions with how to use Slicer. And I think this is really important because technology is only as good as the understanding of how to best use it. And that includes both hardware and software. I have a colleague who is a senior surgeon who likes to say a fool with a tool is still a fool. I don't really ascribe so much to that as to the idea that tools are only useful when they are easy to use, intuitive, and fundamentally rigorous, and are doing what they claim to do. And so I think a lot of the onus is on making the tools and providing whatever training is necessary to inform the use of the tools so that they are as useful, informative, and safe as possible. So that sort of brings us to how do we engineer things for low resource settings. I have been really interested in this idea for some time because medical technology is really driven by profit-making corporations, largely in the US and to some degree in Western Europe and China coming on board a lot. But these are companies and they try to make money, which, no harm on them. But the problem is that it really creates a kind of ecosystem which is not favorable for lower resource settings. And in particular, it means that the companies are intentionally engineering in the use of consumables and single-use parts, because that's how you make money, by continually selling these single-use pieces. And that also requires a regular supply chain. There's also engineered into this the sort of dependency on surgical reps, so folks from the company that come to the operating room for every case to support the cases. And so we really wanted to try to engineer something that was conceived of to avoid some of those pitfalls. So we wanted to make it inexpensive, but we also wanted it to be really simple and robust so that we wouldn't need a surgical rep to be there. We wanted to be low maintenance so that we wouldn't people would need to buy a maintenance contract, which is usually part of these capital purchases that we do. There's a very significant cost for the maintenance contract. We wanted it to be independent of infrastructure. So devices that depend on uninterrupted power supplies at all times, or they crash, may be very problematic in certain settings. As I said, we wanted to avoid consumables. We also wanted training to be part and parcel of the system. So again, the system is only as good as its ability to be used to its full capacity, to be used safely and effectively. And to do the training, we've developed some modules, which I'll show you. We also tried to make everything very user-centered so that it is as intuitive as possible. And then, of course, one of the key tenets of developing any kind of tool is to work collaboratively with the potential users. And so I've spent quite a lot of time working with various colleagues to get their feedback on what we've created to make it better and more useful. And I actually, I did a few years ago spend some time as a Fulbright Global Scholar, which is a relatively short-term opportunity to go to 2 world regions. In my case, it was Sub-Saharan Africa and North Africa. And my project was to work with clinicians and technical experts, particularly biomedical engineering, to help build collaborations between those 2 groups with the goal of kind of fostering this type of innovation. So local, on-the-ground innovation rather than importing solutions that have been engineered for different settings. And there are a lot of efforts that you may know more about than I do to develop technology across different areas. So, for example, technology for blood banking has been developed in order to help facilitate getting blood, getting as many donors as possible and getting blood to the right places. There's been a lot of technology developed for low-cost respiratory support. And I am really interested in learning more about the large scale of this type of development above and beyond kind of the neurosurgical side of things. So I don't know how many of you are neurosurgeons, but just to talk a little bit about what neuronavigation is, I tell patients it's like GPS for the head, and that's because the head is round, roughly, and we don't have a lot of landmarks surgically, and so and the cost of being off by relatively small distances can be quite significant. So millimeters do matter in what we do, and in bringing navigation into the operating room, which started about 30 years ago, what so-called frameless navigation, that has gradually been adopted as the standard of care. Initially for difficult, potentially so-called inoperable lesions, but now it's really so ubiquitous, it's used everywhere. And so why would this be helpful in a LMIC setting? Well, it can make lesions that might be considered inoperable more operable. An example of that might be small, deep lesions. So without navigation, it can be really fraught to try to localize a small, deep lesion. On another scale entirely would be avoiding wrong side or wrong site surgery. So that is also really critically important, obviously. And when imaging is used, whether it's on film or electronically, there can be issues with wrong side surgery. And navigation can help to avoid those because there's an obligatory registration step between the imaging and the patient. It can also optimize craniotomy placement, and that's actually quite important. When we're making our craniotomies, we have to be over the lesion and have sufficient exposure. And as a function of that, when there's some uncertainty, people tend to make larger craniotomies. And the larger the craniotomy, the higher the risk of various complications. So even in my surgical experience, which dates back about 30 years, um, we used to take patients back in the middle of the night for epidural hematomas, subdural hematomas, remote hematomas, um, wound breakdown. That's not a middle of the night thing, but there were a lot more takebacks than there are now. And one of the reasons for that is that we've been able to make our approaches more and more minimally invasive. There's a number of things that have gone into that, better imaging, um, new techniques, microsurgical techniques, but one of those is just navigation and being able to make those craniotomies smaller and smaller. Another kind of low-hanging fruit is placement of a catheter into the ventricle. So this is something we do for the treatment of hydrocephalus, which is very common, extremely common in many developing countries due to neonatal infection and also to myelomeningocele, myelomeningoceles, which is a spina bifida. And to place the catheter into the ventricle can be difficult when the ventricles are small, which can happen in some situations of hydrocephalus. And in general, I think of it as just trying to provide a helping hand to my colleagues who are working in isolated settings with limited resources. When I've gone to work with colleagues in these settings, I've just been sorry, I'm a little bit sick. I've been really amazed at how hard their job is, meaning they are dealing with incredibly difficult cases with very little support. And that includes limited senior colleagues to bounce their surgical plans off of. It includes staff that may not be as trained, limited tools such as perhaps no access to the kinds of tools that we're talking about. And the patients present with very advanced disease. And so they're doing harder cases with less help. And our hope with NousNav was to, kind of try to give a little bit of that um, uh, to help with these difficult cases. So I'm just going to talk for a second about Ethiopia, which I went to Ethiopia last year, and I was really amazed because when I had started talking to folks about global neurosurgery, which was about 15, 16 years ago, we had a meeting, and at that time, Ethiopia had 3 neurosurgeons, and there was a lot of discussion because there were efforts to set up a training program at Black Lion Hospital, which is the kind of lead academic medical center in Addis. And that work happened, and it bore fruition. And now there are 66 neurosurgeons. Actually, there are more than that now. There's over 100. So there's been this tremendous growth in neurosurgeons, but they still have such limited resources with which to work. And this is to me was like a great irony because we generally think of the hardest part about creating neurosurgical capacity as creating neurosurgeons, because making neurosurgeons takes a long time and a lot of expertise. So it's a 7-year residency. But they've done that. They've successfully been training neurosurgeons. They've now have sort of second generation of training. So people who were trained in country are training their successors. But they still don't have access to technology. Um, and one example of that actually comes from the Philippines. So one of my fellows is from the Philippines, and he had practiced there for some time, and he educated me on the fact that they had in everything but the sort of flagship hospital in Manila, no navigation, but that sometimes they needed navigation and it was available to rent from commercial enterprises, but that basically this was limited by the patient's ability to pay because the cost of the navigation rental for one day was more than the rest of the cost of the surgery put together. So there was clearly a need. Um, but as I said, everything is kind of driven by medical device development. And so that was really our motivation for NousNav. And that's what we've been building now for close to 10 years. Um, and as I said, it was sort of conceived of from the get-go to meet some of these obstacles. So this is sort of the general setup. So like a commercial navigation system, the sort of heart of the system is a 3D camera. Um, that's what opened up what so-called frameless navigation in the 90s was the advent of 3D cameras. There are also electromagnetic-based navigation systems, but optical is really the technology most ubiquitous, and it's the most accurate. And then what has opened up the idea of a low-cost approach is that these cameras have become commoditized, so no longer just this sort of rarefied medical application, but used for all sorts of applications. So 3D cameras actually, to some degree, are available on many phones now. They're available on a lot of gaming platforms. And we selected a camera that's a little bit higher end than that because we wanted to engineer in as much accuracy as possible. The camera that we use is called the OptiTrack Duo, although we're constantly looking for other potential cameras to use. And that's used for motion capture largely. So it's used for such things as movie making, for making animated movies. And then the camera is used to track the reference array, which is attached to the patient via this clamp. And this clamp is what we use to hold the head during surgery. This is a Mayfield clamp. There are a number of vendors that make a clamp. And that, unfortunately, is a requirement for the use of NousNav. You have to have head fixation. We've done a little bit of survey work to try to find out how many places already have head fixation. And that number is pretty large in terms of numbers of sites, although there are a lot of sites that don't have it as well, just because there are so many sites. And so then we have a pointer, which the surgeon uses to then point to a spot in or on the head, and then they can view that in 3D on the preoperative imaging. So the other boundary condition is to have 3D imaging. That can be CT or MR. And so we are, by definition, kind of limited to sites that have some of these things, cross-sectional imaging and head fixation. I think that is appropriate because in order to really do brain surgery, you need all of those things. So you need to be able to see the pathology before attacking it. That was really the huge innovation that changed neurosurgery more than anything has been the evolution of imaging so that we could see inside the black box of the head. So we engineered this to fit into a briefcase so that surgeons could take it either home with them to keep it safe, because a lot of places have issues with security of electronics. They could also take it if they work at multiple hospitals, which many of my colleagues do. And they could also prepare their cases the night before or the week before by looking at the imaging using our software. This is the whole system. So it's, as I said, it's the camera. It's some hardware that we sourced from photography hardware. So sort of professional photography hardware is pretty well engineered. It's very nicely made, machined, often out of aluminum, but it's very inexpensive. And then we made these custom parts. So the custom parts are the reference array, the pointer, and this is a holder for the reference array. And right now we have this running with a laptop that's a pretty moderately specified laptop, which costs between $500 and $600. We put 700 here, but it can really be gotten for a little bit less than that. We also thought a lot about how to engineer out the use of consumables. So in the commercial navigation systems, they all use these spheres that are coated with this retroreflective coating. The spheres are actually sold by the company that makes the camera. And actually, I learned recently that that's really how the company makes the money. So it's a little bit like what my husband calls the razor blades scheme. So you buy the razor for pretty cheap, but then you have to keep buying the refills. And so the spheres are really very expensive, something like $20 each, and you need probably 20 to do surgery. And they also require shipping, and they're spheres, so they take up space. You can't just ship them in an envelope. You have to ship them in a box. And I think a lot of folks know that things don't always make it through customs and the postal service. They get lost, or they get stolen, or you need to pay a bribe. So we wanted to try to engineer that out of the picture. This has been a big engineering challenge, which we're still working on. In fact, I have a meeting at 2 o'clock today to talk about markers. But the idea is we need these markers so that they can be seen by the camera. And we are currently making them out of retroreflective tape. So this is tape that's used often on sporting goods. So that people can be seen. So it's on your sneakers or your jacket or your backpack or your bicycle. You can buy a whole roll of this for about $70 and make thousands of markers. And we've done a lot of testing that shows that these are as good as spheres. They have a slightly more limited angle from which the camera can see them, but that is something that can be worked with. As I said, we're huge advocates of open source software, and so this is built on Slicer, which allowed us to make this a relatively streamlined software development. It still took us a few years, really, and tens of thousands of dollars, but much less than it would have if we were building this from the ground up. So we have a number of algorithms that are just ported directly from Slicer in terms of registration algorithms, segmentation algorithms, et cetera. I mentioned my colleagues at Queen's in Canada. They've developed the PLUS library, which we also depend on, and then the open source, that's also open source, and then the camera, as I mentioned. We've also been working a lot on making the software intuitive. So navigation is, on some level, fairly simple. Like I said, it's GPS for the head. It helps that many of us now are frequently use GPS, and so we're familiar with the idea of how you can use triangulation to locate something in space. But still, there's a lot of knowledge that goes into it, and we've tried to make it as seamless as possible, walking people through every step of the way. So step one is to load the images, but then we do something called skin segmentation, where we define the surface of the head. We do target segmentation, where the surgeon defines their goal, their target for the operation, and trajectory planning, where they can look at their approach towards that target. And then the last step for planning is landmark selection. And what we will be doing is then using the skin segmentation plus the landmarks for the registration in the operating room. And then once the registration is done, we can then navigate, and this shows an example of how we navigate on the surface once we're registered, and it shows us where we are relative to landmarks. We've done a lot of testing and continue to do testing to make this as helpful as possible in order to quantify how accurate it is. And right now, it is not as accurate as the high-end commercial navigation systems. I should point out those cost about $750,000. So they're completely out of reach of most sites. And we also have to remember that what we should be comparing ourselves to is freehand navigation. So that's navigation essentially using a ruler to measure from skull landmarks. We've also done a lot of clinical testing. So this is actually my operating room, and we benchmark it against our navigation system, not just on benchtop testing, but also on clinical use testing. So what's it like in real life, where, for example, we're not using a phantom, we're using an actual patient whose skin may have some mobility because we're using the skin for the registration. And then, as I mentioned, training is a critical piece of what we do. We really do not want people to use this in a way that is dangerous, that would be unsafe, and that requires understanding both of the principles of navigation. How does it work? How can it fail? Failure points analysis is really important. And then on just the mechanics, sort of what are the button pushes that you need to do on the user interface. You can see we tried to make the user interface really simple. And then how can you troubleshoot errors? And so we have training available on the website, but I have a person who is a computer scientist. She has been the lead trainer for Slicer for well over 10 years. And so she goes to conferences around the world for basically scientists who are interested in using Slicer, to train them in Slicer. And she has agreed to work with clinicians who want to learn how to use NousNav. And for example, this week she was working with one of my colleagues in Malawi to give him the background to start to use NousNav. We also have a YouTube channel that we're always trying to improve. And then really importantly, we want user feedback. So this is my colleague, Claire Kerekezi. She is a neurosurgeon in Kigali, Rwanda. She was a fellow at the Brigham for about 10 years ago or so, and also did a formal tumor fellowship in Toronto. So she's very well trained in all contemporary aspects of neurosurgery, but up until now, she's had no access to neuronavigation at all. And so this is an example of her taking her colleagues through how navigation works with our system. Finally, we have ultrasound, which is what I think of as kind of the next steps. Ultrasound is a relatively inexpensive imaging modality that can give you live images, and we use it every day. As I said, we have intraoperative MRI, but we still use intraoperative ultrasound because it is so much easier and less workflow disruptive. basically the surgeon controls the imaging instead of having to break surgery completely, take everything off the field and obtain an intraoperative MRI. And we're very interested in harnessing low-cost point-of-care ultrasound. So there are a number, actually, I saw somebody had the butterfly logo, one of our audience members, Heather Harmon Donahoe.
Hi,
So
Dr. Golby, I'm from Butterfly. Thanks.
you're from Butterfly.
Yeah.
So this is not your device, but on the left, but it is actually a Butterfly device on the right. There are a number of vendors now that make these low-cost point-of-care ultrasounds. And this is my colleague Claire. Again, we were able to donate one of our Butterfly ultrasounds to her for her use in intraoperative settings. And we're really interested in trying to engineer that so that it works better. So that's one of our current efforts. And in order to make ultrasound as interpretable as possible, we also have a big effort in terms of image analysis. So ultrasound is a great tool, but it's hard to interpret, especially for neurosurgeons for whom this is not part of our workhorse the way it is, say, for either obstetrics or cardiology, where they use ultrasound all day, every day. And so tools that can make this more interpretable for the surgeon. So for example, ultrasound intraoperatively is usually not in our cardinal planes, axial, coronal, and sagittal. It's usually in oblique planes. So one of the things that can be helpful is to provide landmarks or to reslice it into other planes. We also are really interested in being able to make data available to collaborators so that they can develop their own tools. And so we recently released this REMIND data set, which is 114 patients undergoing surgery in the Amigo suite. And so these are patients who have both several intra-op ultrasounds and intraoperative MRI. And so we have what you might call the gold standard intraoperative MRI. And we also have ultrasound, and so that people can develop their own algorithms to help make that ultrasound as helpful as possible. So that is a brief look at what we've been working on in this relatively small niche of intracranial neurosurgery. These are some of our colleagues very interested in developing further our collaboration. So there's a lot of red dots that we're still working on launching our collaborations. And this is our goal, is to have it be as ubiquitous as it is in the developing world as it is in the US. And I'm not sure if this video is going to play. Yeah, so this is my colleague, Magad Guy in Dakar. I was able to go there. So she's using the system to plan out her craniotomy.
En plein milieu, la lésion ici, la limite externe. Externe, super. Allez, notre lésion est là. Son volet est déterminé.
So she says, there you go, that's your approach.
Tu viens laver.
Okay. So I'm happy to take any questions. I used up probably more than the 30 minutes, Ria, that you said it might be. But I hope this is interesting. I don't know, again, how many of you are neurosurgeons or have experience with neurosurgical cases. Our goal is to disseminate this as widely as possible. There's a lot of steps that are still to go in that, which include how will we distribute it, how will it receive regulatory compliance, approval, etc. And, maybe this is an example of trying to make technology simpler and more accessible in neurosurgery that can serve as a catalyst for other surgical, obstetrical, anesthesia, et cetera, needs. As I said, neurosurgery in the US has really been a leader in technology. A lot of that technology then got adopted by other specialties. So, for example, navigation is now used for cardiac ablations, for prostate interventions, for any number of things, ENT surgery. So that's our goal. How can we harness technology to do more with less? This is my team, and I'm happy to take any questions.
Thank you so much, Dr. Golby. This was an amazing presentation, and we've been getting really great feedback in the chat. People are learning a lot. People are really interested. I have a question here from Amna Hussein. She says, thank you for the excellent session and for your efforts to support low and middle resource countries in improving access in surgical care. I would like to know how I can contact Dr. Golby after the session. Is that something you'd be willing to do?
Sure, yeah. You can share you have my email.
Yes.
You can share my email. I do have to say I am, my bandwidth is limited. I have like a lot of things that I'm working on, of which this is just one. And I get hundreds of emails every day, many of which are people who are reaching out to me. So I'm happy for folks to reach out. I just have to put a caveat that I may or may not have the bandwidth to answer. One of the things I'm working on actively right now is getting a infrastructure in place so that I'm not the only point person for this, because I just can't be. And I also appreciate that we're slowing the adoption of this because of my limited bandwidth. So I need to bring some kind of professional help on board, and then more collaborators will be incredibly important, because that's the other side of the story. We need both sides. We need me and my team and our collaborators that we already have, but we also need new collaborators.
Speaking of collaborators, I was wondering if you could walk us through the process that you go through in order to recruit collaborators, to establish those connections, and to maintain them to the point of implementation and testing.
Yeah, well, I mean, initially I started with people that I know very well. So Claire was my fellow, and so she and I go way back. And then we have also built on collaborations, larger collaborations. So the collaboration with Dakar happened in part because of our associates at Queen's who were working with the urologists in Senegal. And then I have various colleagues who have already established partnerships with their colleagues in the developing world. So I have a colleague from Australia who's working with Malawi. I have a colleague at the Brigham who are working with one and only neurosurgeon in the Gambia. I have a colleague from University of Alabama who's working with folks in Vietnam. And so we're trying to build on sites that already have some relationships, again, because one of our most important priorities is to make sure that we don't get off track early. If folks are not equipped to use it in a safe and effective manner, then that really becomes a little bit counterproductive. We don't want people to have problems from the adoption of the technology. We really want to try to accompany them in that adoption of the technology, so that they are able to do it in a safe and effective manner.
I think that makes a lot of sense. I'd like to open it up to see if anyone else wants to jump in with questions. I do have some more questions as well, but I want to make sure everyone gets their chance to say something. Dr. Golby, I was wondering if you could speak to the differences you found in working across sites within Africa, for example, in different regions versus in the Philippines or in Vietnam.
Well, we haven't actually worked in the Philippines and Vietnam yet. These are goals. I think the one of the biggest issues is who is the personnel and what's their experience. So one thing I noticed is that young people, um, even in really resource limited settings, are all pretty familiar with computing and computer science. And so that I think young people are inherently better at adopting technology. Um, I'm old enough now that I have to like ask my kids to help me with technology. Right. And so one good thing is that most neurosurgeons in developing countries are young because there haven't been any. So they're by definition, they're young. So that's one thing. Another thing is to have ideally some experience with navigation before they use the system. So a good number of people uh, who are training have had at least some exposure because they spend some time in a higher resource setting. So for example, Claire, as I said, she trained in Morocco, which is sort of a middle income country. They have a little bit of access to these more resource intensive things. And then she spent a year in Toronto. And so she's able to bring that exposure back home and then share it with her colleagues who may not have had it. Or my colleague, Abel in Addis, he spent some time in India and had some exposure to navigation there. So I think previous experience is really critical. The other piece right now, which is still very helpful because this is still young technology that sometimes doesn't work perfectly, is to have access to folks who are more technical. And so my colleague, Magat in Dakar, she has the ability to work with our collaborators that are at the technical university there. And he has a team of students and grad students who can help with that sort of the more technical side when the software is reaching some sort of incompatibility issue or something. So those are kind of the three pieces: youth, some experience with navigation, and some technical support.
That makes sense. And we do have one last question in the chat, Dr. Golby, but if you have to go, I completely understand also.
I
But if
do.
you have a
I have a
minute.
patient at 10, but
Okay.
I see the question from Amna. I don't have experience working in conflict affected regions, but I don't see an inherent reason why we couldn't. The biggest challenge is being sure that we're not displacing more essential needs. I'm the first person to admit that you first need to be able to deliver babies before you start thinking about making neurosurgical care better, and other sort of lower hanging fruit.
All right. Well, thank you so much. I want to be able to respect everybody's time, so let's go ahead and wrap up this session. But thank you so much for joining us, Dr. Golby. Everyone else, I will be sending out notes as well as Dr. Golby's contact information with the caveat that she is a very busy woman and
Yeah. And thank you.
and
And
has
as I said at the beginning, I do hope to keep the conversation going with the G4 Alliance. I know Gail Rousseau very well for the last 30 years. So thank you.
Thank you so much.
Bye.